Welcome back, everyone. We're going to go ahead and get started. All right. So we are officially on the final stretch today. So next up this afternoon, we have another special guest speaker from the Center for Rural Health Research. Meit is joining us today for an educational presentation to describe health inequities along with what is known about rural health inequities and how they vary by geographic region. He will share measures of rural prosperity that can help us understand the factors of risk and resilience in our rural communities. And Michael will highlight the rural strengths and assets that can be leveraged to improve community health and well-being. Welcome, Michael.
Thank you. I am very excited to be here. So just a quick show of hands. How many of you have followed a NASA astronaut when giving a presentation? All right. So I just want you all to remember that, okay? Remember that for the next hour or so.
I think they want you on this side.
On this side?
Yeah, this side.
This side. Oh, okay. No worries. So I am genuinely really happy to be here. So I have a lot of Kentucky roots. I'm actually the black sheep in my family. I'm the only person not born in the state of Kentucky. My mom was one of 8. My dad was one of 2. I've got about 40 first cousins, the only one not born in Kentucky, including my brother. So again, very special place to me. And actually both of my parents are UK pharmacy grads as well. So I'm going to talk to you about health equity, poverty, and rural resilience. Going to take you through a little bit of a journey here. We're going to talk about rural health inequities, starting at a high level, United States. Then we're going to talk about Kentucky. And then I'm going to talk a little bit about deaths of despair. That's focused particularly in the Appalachian region. That's where we've done a lot of our research. Going to talk about measuring and building prosperity, trying to kind of flip that a little bit to think about not just poverty, but how do we build prosperity and resilience? And then I'm going to end with resilience. And this is really important to me because whenever we talk about rural health, we tend to talk in really negative terms. It tends to be very dystopic. We know there are challenges. Typically, we're funded to explore those challenges. So we're good at highlighting those, but we often don't talk about what's good about our rural communities. And I think that's a really important part of the story that we need to be telling more and more. So again, starting at this high level in the United States, as you all know, you are living in the healthiest nation in the world with the best healthcare system in the world, right? This is our American narrative. We are exceptional in everything we do, including healthcare. Well, in fact, we probably are exceptional at a lot of things. Healthcare, unfortunately, we struggle, and the health outcomes really show that. So this is some data. Some of you may have seen this. Life expectancy in the United States has trailed other developed nations for a long, long time, but that gap has widened and COVID hit us a lot harder. That drop at the end is COVID. And when you look at how we fared compared to how other nations fared, we have a lot that we really need to be focusing on in our country. So this is data from the Centers for Disease Control and Prevention. They've done a study and they're actually redoing it right now. It's going to come out very shortly. But they did a study where they looked at health disparities across the leading causes of death. They looked at the 5 leading causes by geography. And a couple of things here I do want to highlight because I'm going to come back to this again. But rural definitions. There are, by the way, 72 federal definitions of rural. And there's only one theme in every federal definition of rural, which is that every single one is a definition of exclusion. So what they do is they define urban, and if you don't fit into that category, you by default are rural. So in fact, despite there being 72 definitions, there is not a single definition of actual rural in the United States. But what we call them doesn't make a whole lot of sense either. So again, just to point this out, micropolitan and non-core are our 2 rural definitions. I wish they called them something different, but micropolitan and non-core are the definitions of rural. The other 4 categories are urban. And what you see is for every leading cause of death, when you get out to those rural definitions, we have those inequities. People who live in rural areas are more likely to die from all of those 5 leading causes of death. And in fact, if you expanded this out, they are more likely to die from 9 of the 10 leading causes of death. So what does this look like here in Kentucky? So I'm going to walk you through this slide a little bit because there's a lot of information, and I know it's small, but I love this because there's a lot of information. So what you're looking at, again, it's those same definitions. So orange and red are our 2 rural definitions. This is looking at those 10 leading causes of death for the state of Kentucky for males. 100, that's the national average for each of these leading causes of death. So anything above the line means that you're doing worse. Anything below the line means that you're doing better than the national average. So the first thing you'll notice is that the state of Kentucky doesn't do particularly well. Almost everything is above the line. True for my state of Tennessee as well. We tend to be on that bottom edge of the nation, of the states in the nation in terms of health status. But even within this, look where those reds and orange dots are. Again, it's similar to what that national study showed, but here within your state, you have inequities based on geography. People who live in rural areas fare worse on these leading causes of death. And just to put this in context, this is scaled so that lower respiratory disease, this red dot is at 300. That means that if you are a rural man in the state of Kentucky, you are 3 times more likely to die from lower respiratory disease than men elsewhere in the nation, 3 times. And you are 75% more likely to die from cancer, 2.5 times more likely to die from diabetes. Where you live should not determine the health outcomes that you are able to achieve. And this is just as true for women. So this is the same slide for women. And again, we have those same outcomes. We have 3 times more likely to die from lower respiratory disease, 2.5 times more likely to die from diabetes, about 2.3 times more likely to die from heart disease, again, across those leading causes of death. So that's really all I'm going to share with you on the leading causes of death and the geographic inequities. I'm going to dig a little bit more, though, into deaths of despair, because that's one of the big drivers in Appalachia. It affects the health outcomes here in Kentucky. How many of you are familiar with deaths or diseases of despair? You've heard that terminology? How many of you hate that terminology? There are a lot of people who know that terminology, and it just rubs them the wrong way. I'm one of those people. I do a lot of work in this area, but it kind of grates me because I feel like it's a little bit of victim blaming. We are describing what people are feeling based on what's happening in their community and attributing what they experience in terms of health outcomes to how they feel. What we should be doing is moving upstream to talk about what are we doing to those people that makes them feel despair. And just so you know, when we're talking about deaths of despair, this is what we're talking about. It's 3 primary causes of death. It's overdose, it's suicide, and it's alcoholic-related liver disease. So again, what is happening to people in our communities that those are drivers of health inequity? And I would argue it's less about their feeling despair than it is about our having left these people behind in our communities. It's a societal issue, and we need to be looking at that. So I've started referring to these as diseases of neglect, because we are doing something by not taking care of people in our communities, and that's where we really need to be changing this dynamic. What I think that is, and I'm going to come back to this throughout my presentation, I think we've left these communities behind economically, and that's where a lot of that neglect comes from and the despair that results from it. So again, just to dig into this a little bit, we've done this report now for the Appalachian Regional Commission 3 times. For those of you who work with mortality data, you know this, but mortality data lags by about 2 years. So when we did the study in 2017, we were looking at 2015 data. We updated in 2020, looking at 2018 data. And then we did it most recently in 2022, looking at 2020 data. That one was important because it brought in the first year of COVID data. And now we're really happy. The Appalachian Regional Commission has actually funded us to do this annually. But I'm able to show you 3 time periods now with this data. You all probably know this, but this is the federally defined Appalachian region. And I show this because Kentucky is featured very prominently among central Appalachian counties. And then this is some of the data. So just to compare the two. So what you see on the left is actually not diseases of despair. That's all-cause mortality. So that's all deaths. So diseases of despair are essentially one of the drivers for that all-cause mortality. But what you see, Appalachia is the blue line. The rest of the United States, excluding Appalachia, is the gold line. What you see is that there have been disparities all across the board for all-cause mortality. There have been disparities between Appalachia and the rest of the nation. And during COVID, that got worse. And again, what you'd expect, that's true for these deaths of despair, these diseases of despair, diseases of neglect as well. What's notable here is how the delta between these have expanded over the years. This has gotten worse. The other thing that's heartbreaking for those of us who work in this field is we were really excited in 2018 because we saw that first dip in these causes of death in decades. It was largely driven by a dip in overdose mortality. That was sustained in 2018, from 2018 to 2019. We were excited, and then COVID hit and everything went sideways. And, you know, I showed you at the beginning the spike in mortality due to COVID, or the dip in life expectancy due to COVID, the flip side of that. COVID had impacts way beyond COVID itself. Overdose deaths spiked, heart disease deaths spiked because people were afraid to go to emergency rooms. All causes of death got worse as a result of COVID, and that is absolutely true when it comes to our deaths of despair as well. So just a couple more slides I want to share with you on this. So this is looking at these deaths of despair by cause across those 3 time periods. What you'll see is that overall, Appalachia is about 37% higher than the rest of the nation. But note that the bars go up. Okay, that's really important. This isn't something that's stable. The disparity is stable, but the issues have gotten worse in Appalachia and in the rest of the country. Similarly, 2015, we were saying that overdose mortality was 65% higher in Appalachia. And here in 2020, when we did the 2022 study, it was down to 50% higher. So the disparity actually decreased, right? We're achieving health equity, right? Well, if you look at that data, what actually happened is in Appalachia, the rate went up 70%. It got 70% worse, but the rest of the country, it got twice as bad. They're catching up to us. That's not the way we want to eliminate health disparities. So it's a good lesson for public health is when we talk about eliminating health disparities, there are 2 ways to get there. The people who are doing worse can get better, but also the people who are doing better can get worse. And that's not the way we want to achieve health equity. So this is actually, I think, the most important slide from our whole report, most important chart from our whole report on deaths of despair. And this is looking at deaths of despair by age group, men and women. Men is on the left, women is on the right. First of all, you'll notice that the overall rates, the raw rates, are much, much higher for men, but actually the disparities are greater for women, which is intriguing. So you'll see here for the age 25 to 44 year age group, for men, if you are living in Appalachia, you are about 50% more likely to die from those causes of death. For women, it's about 60% more likely. So again, that disparity is greater for women than it is for men. But really the reason I like to point this slide out is that age bracket, 25 to 44 years old. That is people in their prime working years. So the economic impact for Appalachia is significant. But even more importantly, that's people in their prime childbearing and child rearing years. And we need to be worried about what's happening to the children in our region. We talk a lot about adverse childhood experiences, or ACEs. This is driving a lot of the ACEs within the Appalachian region, and we need to be very alarmed by that and focused on how we create resilience in these children who have been impacted, so we prevent future generations from following the same pattern. Last couple of slides on this. One thing I do want you to be aware of is that Appalachia, I'm showing you a lot of that data in aggregate across the 423 counties, but it's not the same throughout the region. Central Appalachia tends to have higher rates than the rest of the region. Southern Appalachia actually tends to have rates that are lower than the rest of the region and the rest of the country. But if you look at the states that are most impacted, it is Central Appalachia: West Virginia, Maryland, Kentucky, Ohio, and Tennessee. And then the last thing I want you to see is the impact of opioids in particular on driving this. So again, those three causes of death are overdose mortality, suicide, and alcoholic-related liver disease. But when we talk about overdose, the driver tends to be opioid overdose. And again, it varies somewhat by state, but you'll see there's a high of 92% of the overdoses in Maryland, in Appalachia, Maryland, are opioid related. In Kentucky, it's 77%. It tends to be the big driver when we're talking about these deaths of despair. So one of the things, and I'm going to come back to these throughout the presentation. So one of the things I really want to leave you with is tools that you can use in your community. And we've developed a lot of tools that I'm really proud of. These are two of them. It's our Appalachian Overdose Mapping Tool and our United States Overdose Mapping Tool. You'll see the websites there. Within these tools, if you pull them up, they're free, available online, federally funded tools. You can create these heat maps for overdose across the United States. And more importantly, you can click on a county, and I'm going to show you that here. You can click on a county and actually see the data for that county and see how that county compares to a state and to the nation. So in Rowan County, overdose mortality rate was 46.4 compared to Kentucky of 48.5, compared to the United States of 28.7. But you also get all that data across all the different socioeconomic and demographic indicators for the county. We want people to be using these tools for community planning, for writing your proposals. They are easy to use data sources that you can pull this information in a moment and have it at hand. The other cool thing about these is you can share this page up top, and it will actually populate into an email that you can send to stakeholders, policymakers, community organizers, anyone who you want to be part of this dialogue. You can also print it out as an 8.5 by 11, take it to your meetings. A lot of good ways to use these tools. I'm going to show you some of our other tools as well. Within these tools, there's also a treatment locator, and you can zoom in, you can get addresses. It's good, but it's only as good as the data source, which is true for all of these tools as well. This data comes from SAMHSA. It's not updated as regularly as we'd like, but again, it's a good starting point to get some of that treatment location information. Another tool I want to tell you about, the website is at the bottom here. It's rei.norc.org. It's the Recovery Ecosystem Index. This was a tool we developed most recently, actually second most recently. And essentially what we wanted to do was think about how do we measure the strength of what we call recovery ecosystems at the community level. And if you're not familiar with that terminology, I think it's a great terminology to start to use. The idea behind a recovery ecosystem is that we need to have supports in place at the community level so that when people finish substance use treatment, there's a support system to help them maintain that sobriety, to be successful in their long-term recovery. And what we've often seen is people, after they go through treatment, if they enter the same environment, if they don't have stable housing, if they can't get a job, it's way too easy to fall back into substance use. So this is thinking about how do we create that community support that embraces the person and really helps them in that long-term recovery. So we came up with 14 indicators, substance use treatment indicators, SUD support indicators, and social factors that we were able to gather for every county in the United States, and created, again, a national mapping tool where you click on that and you can access data on any of these indicators for any county in the United States. This is what that tool looks like. What I think is really interesting here, and something you should be proud of, is that Kentucky tends to be more green and blue, which are higher scores. So the recovery ecosystems in Kentucky are stronger than we see in a lot of Appalachia and across a lot of the southern states in particular. And again, we do this with all of our tools. So this is Pike County in this case, but this is really, I think, the nuts and bolts of every tool we develop. Is we want to make sure that you can get the data for your county compared to your state and the nation. So for Pike County, you can see they have 17.1 substance use treatment centers per 100,000. That's 4 times more than the nation as a whole. Really good, strong indicators, and you can see how your county compares. More importantly, you can see where the deficits are and send this to those stakeholders and policymakers and people who are doing the planning so that you can figure out what do we need to strengthen to build a stronger recovery ecosystem in our community. We, by the way, I should mention, we partnered with the Fletcher Group on developing this tool. And if that name sounds familiar, it is Governor Ernie Fletcher, the former governor of Kentucky, who started a lot of the recovery housing initiatives in Kentucky, and still to this day is doing a lot of that work in his post-political, semi-retired career. So really neat, able to partner with him on that and actually bring that Kentucky flavor back to this work as well. So this is where I want to shift gears, and I'm going to talk a little bit, and you've heard this throughout the day, social determinants of health. I prefer the terminology social drivers of health. I prefer that not because it's simpler. I think that's actually not a bad reason also, because I do think determinants is probably too complex a word. But what I like about it is the word determinant is problematic. So when we talk about determinants, it sounds like it is set in stone. It is predetermined. And we don't want people to go into addressing these issues thinking there's nothing you can do about them. So I just like using the social drivers terminology because I think it is a little bit softer and more empowering for people working at the community level. So these are those social drivers. But I'm only going to talk about one. I'm really only going to talk about economic stability. I'm going to do that from the context of poverty and prosperity. The reason I do that is because I think it's the most important one. Now, you may disagree with me. They're all important. But I think if you live in poverty, if you do not have economic opportunity, it's hard to achieve any of these other social drivers. It's hard to have good educational opportunity. It's hard to have good food access. It's hard to have stable housing. Poverty to me underpins all of this. And if there were one silver bullet to lift up our people and make them healthier, it would actually be to improve the economic situation in their communities. I think that, what is the saying? A rising tide. Thank you. I wasn't going to get there. Thank you. A rising tide lifts all boats. And that's the rising tide we need in our rural communities. And this is another one of my favorite slides. And this is kind of the opposite of that rising tide. So as a public health, a rural public health person, I am asked all the time by my do-gooder, well-intentioned public health colleagues who tend to lean a little bit left, what is wrong with those rural people? Why do they vote against their self-interest? That's when you hear a lot, because we know what someone else's self-interest should be, right? Hear it a lot. But why are they angry? Why are they disaffected? Why don't they vote like we want them to vote? Whatever it may be, we hear it all the time. And there's, within public health, some palpable anger towards rural people for being more conservative, for, whatever it may be. Well, how did we get here? So what this slide shows is rural versus urban job growth since the economic recession of 2008. Okay, so this goes back 15 years. What I want you to see is that prior to the economic recession and even through the economic recession, rural and urban were overlapping lines. Rural was doing just as well as urban. The recovery since the 2008 economic recession has been exclusively in urban recovery. If you look this out, this chart ends at 2018, rural still hasn't recovered from the economic recession of 2008. That's lost jobs. That's a lot of jobs that went overseas. That's changes in energy production, good or bad. It impacted our rural communities disproportionately, and we neglected them. We did not help them pivot to something new. When people want to know why are rural people disaffected, why do they feel like they've been left behind? My answer is because we left them behind. And if it were you, you might be a little bit pissed off too, and you might be willing to throw the dice if somebody promises you something, whether you think they're going to deliver or not. What do you have to lose? So we need to come at this with a little bit of empathy for what has happened in our rural communities. And we need to figure out how do we create that reinvestment and lift these communities up economically, because short of that, I don't see a good solution. So educational systems are struggling in rural communities. Why is that? Loss of tax base. Why is it? Jobs have left. People have left. We're all concerned about rural hospital closures. Loss of tax base. Jobs have left. People have left. This underpins so much of the experience that we're seeing across rural America. So what I want to do, this is an exercise that I think is kind of fascinating. So what we did is we compared the 2% of the richest counties in the United States to the 2% of the poorest counties in the United States. 3,124 counties in the United States. 2% richest, 2% poorest. Now this is not urban versus rural, but 90% of the richest are urban, 90% of the poorest are rural. So it kind of is. So we look at years of potential life loss, one of our standard public health indicators, and lo and behold, 3 times more years of potential life lost in our poorest counties as compared to our richest counties. People in our poorest counties are twice as likely to smoke. They're 50% more likely to be obese, half as likely to have any college education. And then the one that just to me is the gut punch, children living in those 2% poorest counties are 6 times more likely to be living in poverty. 6 times. That's the difference between rich and poor, urban and rural. So what does this mean here in Kentucky? Oh, that slide didn't work. So that is supposed to be not a map of the world. I don't know how that happened. That's interesting. That should be a map of Kentucky with your 5 richest counties and your 5 poorest counties highlighted. Luckily, I did put them up there so you know what counties they are. The poorest county in the state of Kentucky is Wolfe County. Richest county is Oldham County. So this is going to be really, really small, but Wolfe County per capita income is just under 25,000. Oldham County, it's about 100,000. Within one state, within your state, fourfold difference between the poorest county and the richest county. And let me tell you, your state's income disparity is lower than most. When I do this presentation in most states, it's usually 6 times. So 5 poorest, 5 richest. So let's look again at families living in poverty. So the percentage of families living in poverty in the poorest counties is almost 5 times that of the richest counties within Kentucky. One of the things we like to do, and I'm only going to do it for this, I could run through some more, which I think is fun, but only going to do it for this because I'm conscious of time. But when we look at this graph, so 1 through 51 is every state in the nation plus the District of Columbia. The national average, 9.5% of families live in poverty. Kentucky ranks very low on this, 48th in the nation with 13% of families living in poverty. But what if? What if within Kentucky we aspired to be doing as well as those 5 richest counties? What if every county were doing as well as the 5 richest? Well, guess what? Kentucky would suddenly rise up to 8th in the nation. Okay, and of course the opposite is also true. You'd be off the charts, that's no surprise. But I've done this presentation in a lot of states. You guys rank 48th. Minnesota ranks 1st. But when you look at the 5 poorest counties in Minnesota, they're down near 50. So there is, so when you rank every state, Minnesota's number 1 and Mississippi is 51. And what I like to say is there is a Minnesota in every state and there is a Mississippi in every state. And in Mississippi, you're going to find a Minnesota. In Minnesota, you're going to find a Mississippi and everything in between. So again, if you were doing as well as those 5 richest counties, you would be up there sandwiched between Vermont and Connecticut. You would be a liberal northeastern state. How about that? So again, I could do this for any of these, but this is what this looks like for each of the 10 leading causes of death. So again, this is just comparing the 5 richest counties to the 5 poorest counties. Look at the difference in heart disease, 173 per 100,000 versus almost 300 per 100,000. Every single leading cause of death, you have a disparity. Alzheimer's is very close, but every other one is very significant. Stroke, cerebrovascular disease, twice as high. Lower respiratory disease, twice as high. And again, heart disease and cancer are the leading causes of death, but don't let the bars distract you from the disparities. Suicide. People who live in the 5 poorest counties in Kentucky are 50% more likely to die by suicide. Okay? So we say it all the time, got to keep repeating it. Where you live should not determine your health outcomes. And that's really, I think, what's important here. So I want to shift gears a little bit. I'm going to share another one of our tools with you. And this tool is our prosperity index. So kind of similar to what we did with that recovery ecosystem index that I mentioned, we also wanted to think about what are indicators of prosperity. We wanted to have data that were available for every county in the United States and things that could be changed through intervention. And we wanted to be not only looking at deficits, but also looking at resilience factors, assets. So you'll see risk and resilience, economic and social factors, and we came up with 4 indicators per quadrant. So where you find this tool is here. It's ruralhealthmap.norc.org. So this is a tool that we developed for the Centers for Disease Control and Prevention. I want to highlight the base tool just because there is so much awesome information in here. Again, if you are doing any type of proposal or community planning, I want you to use this tool. Within this tool, we've got a lot of COVID data because that's how we paid for it. But we also have that prosperity index, which I'm going to show you. We also have causes of death. So within this tool, you can heat map any of those leading causes of death. and you can click on a county and you can get data for any county in the United States, any county in your state. For each of the leading causes of death, you can get your COVID data. There's all kinds of other information. There's food desert data. There's different socioeconomic and demographic data. Wealth of resources within this tool. This is what it looks like when we map the prosperity scores, though. It looks similar to the REI tool, the Recovery Ecosystem tool, because we use the same architecture, but the map itself looks very, very different, and Kentucky doesn't look green in this one. So just see if people are paying attention here. Can anybody name this? Mississippi River, yeah, it's the Delta region. Through here, that's referred to as the Black Belt because of the rich soil. US-Mexico border region. I know you know Central Appalachia. And then anybody want to guess? Those are tribal reservations, okay? So I'm going to show you the prosperity index compared to a few other maps. And I will, it's like pictures worth 1,000 words. I don't have to really describe a whole lot. Probably will, but I don't have to. So now I'm comparing the prosperity index to persistent poverty counties in the United States. It's the exact same regions. So for those of you not familiar with persistent poverty counties, I'm going to tell you the definition because it's a mind blower to me. Been doing this for my whole career. It's a mind blower to me. To be defined as a persistent poverty county, more than 20% of your population needs to live below the federal poverty line since the 1980 census. And every census since 80, 90, 2000, 2010, 40 years of intergenerational poverty gets you the designation as a persistent poverty county. And it is Central Appalachia, the Black Belt, the Delta region, the US-Mexico border region, and tribal reservations. There's no accident here. Now I'm showing you a map of cardiovascular disease. This map is created through that rural mapping tool I showed you. Okay. And then this is a map of respiratory disease. I could go through any of the leading causes of death with the exception of one, actually with the exception of two, and you would see the same trend. Anyone want to guess what the two are? Homicide is one. Homicide is one. Homicide tends to skew more urban than rural for men. For women, homicide rates are higher in rural because men kill women in rural. The other one, it is accidents, but it's specifically overdose. So overdose is higher in rural, but it doesn't follow the same pattern as persistent poverty because the pharmaceutical industry put their thumb on the scale and marketed the pharmaceuticals in different communities. Central Appalachia was one of them, but the Northeast was another one, which tends to be higher income. So it kind of skews that data. So I'm going to show you 3 more maps, which I think are the ones that are just kind of mind-blowing to me. So now on the left is a map of where we have the highest concentration of African Americans living in the rural United States. Okay? Down south. Yeah, down south and in the Delta region. Delta and down south. Now, this is a map of where we have the highest concentration of Hispanics living in the United States. Okay, noticing the similarity here? And then this is where we have the highest concentration of Native Americans living in the United States. None of these things are happening by accident. All of them should make us angry. The inequity that we see is rural, but it also ties to race and ethnicity, and there's an intersectionality between the two. All of this is a call to action. So I mentioned that Wolfe County was the poorest county in Kentucky. So when we look at the prosperity index, just like all of the tools, you get the data for your county, you can compare it to your state and compare it to the nation. Something weird happened when I pulled this. This should say Kentucky, not undefined. I think I got that fixed since I pulled this. But if you just look at these, I'll read some of them off because I know it's small. Poverty rate in Wolfe County is almost 30% compared to 17% for the state. The self-employment rate is 1.7% compared to about 3% for the state. Number of nonprofits per capita is about 20 compared to 25 for the state. One of the ones that's really fascinating to me, which I think is one of the most fascinating indicators of social engagement, is the voter participation rate. People who are disaffected, people who are left behind, tend not to vote. Voter participation rate in Wolfe County is 48% compared to 56% for the state. So what does this look like in your richest county, Oldham County? So the poverty rate is less than 6%, about a third what it is for the state. The self-employment rate is 6% compared to 3%, so about twice as high. And look at the voter participation rate, almost 71%. This has impacts that really cut across how people engage with their communities. And I think that's what's important here. So again, this, just like all of our other tools, we want people to use this to think about where are the areas where we can strengthen prosperity and resilience within our communities. So this is the last section I want to talk to you guys about. I'm going to go negative before I go positive, because this is the story that we get about rural America. These are stories about rural Appalachia. It is dystopic. This is a whole series of stories from the Washington Post. If you read large city media outlets, rural America, everybody is addicted, nobody works, everybody is disabled, everybody is poor, on and on and on. The problem with that narrative is that if we want to bring investment to our communities, and this is what people are reading, if I'm sitting in Washington, D.C., and these are all the articles I see about Appalachia, I'm not putting my business in Appalachia. It creates this self-fulfilling prophecy. And the thing I always tell people, the thing I want people to know, we have challenges in rural America. We have challenges in Appalachia. Absolutely. Our substance use challenge is formidable, but it's not defining of our region. So what happens is if the substance use rate within a county is 4% in your county compared to 2% nationally, it's twice as bad in your county, right? And the media come in and they go, oh, it's twice as bad. And it's true, but they never talk about the 96% of the people living in that community who are healthy, productive, looking for opportunity. This shouldn't be the nature of defining our communities. And that's really what we have to get beyond. So that's why I like to focus on strengths and assets. We had the opportunity to do a study for the Robert Wood Johnson Foundation, and it was one of my favorite studies ever. So I mentioned this at the beginning, but as rural researchers, we are tasked with describing problems, almost invariably. And it's one of these things that makes me guilty, because at the end of the day, we put out these articles and the media picks up on it, and we are contributing to this negative narrative, and it's a problem. Rarely does somebody give you money to talk about opportunities and assets. They sent us around the country to meet with almost really random rural communities, which was kind of cool, because we didn't go to places where we knew something good was happening. We went to places where people were willing to talk to us. And we just sat down and we said, tell us what's going on in your community that's good. What happens when there's a problem in your community? How do people come together? How do you solve problems? And it was a slow conversation at the beginning because I will tell you one of the challenges we also face in our region and nationally is that many of our own people have bought into the external narrative about them. It's a problem. But once we were able to get them opening up, this is what we heard. We have a close-knit community, a lot of self-reliance. When there's a problem, the community comes together. The faith community comes out of the woodwork. We have a strong work ethic. We really need to be highlighting that one. Collective efficacy. We take care of each other. And then my favorite was this idea of innovation. And we heard this every single place we went. And it was kind of different flavors of the same story. But what we heard is we're in a poor rural community. I heard this in New Mexico. We went to a small town, Deming, New Mexico, near the border. And I thought they said it the most compelling way of anybody. They said, nobody is throwing money at Deming, New Mexico, but we've got problems we need to solve. So we get together around a table and we figure out solutions. And guess what? They're able to solve their problems and generally do it without spending a whole lot of money. That is what we call innovation, right? And I left this study really convinced, genuinely convinced, that all of the problems in rural America and probably all of the problems across the United States have in fact been solved. We just don't know by whom, and we don't know how, because they're not looking for an award, they're not writing it into a grant proposal, they're not reporting it back to a funder, they're just doing it to solve their own problems, right? If we had a way to systematically identify, describe, and replicate rural innovation, we could move things ahead, and rural could be the lead in moving things ahead. So that's one of the things I want to leave you with. Last thing I want to leave you with, I want to take you back to this chart. This is that map of persistent poverty. And as you know, Eastern Kentucky, unfortunately, is well represented in this map. And if you believed that social determinants were in fact determinant, you would tell me that nothing good could be happening in Eastern Kentucky, right? So now I'm showing you a different map. And you can see all of these counties across Appalachia, all these states across Appalachia. Kentucky looks a little different here. Eastern Kentucky looks a little different. So what this is 2 data points. We looked at overdose mortality data from 2 points in time. We aggregated 5-year data, 2012 to 2017, compared to the 5 years before that. And the green counties are the counties that had the steepest decline in overdose mortality. The red and brown counties are the counties that had the steepest increase in overdose mortality. Okay? This is rural innovation. This is collective efficacy. This is building a recovery ecosystem. Okay? So I'll tell you the quick story because I think, how am I doing on time? 12 minutes. All right. Okay. I'll try to be quick. I'll tell you a quick story because to me it was kind of telling. So the reason I found out about these counties, it was not because we were all that brilliant. I literally got a call from a reporter at the Lexington newspaper who was digging into the data county by county. We weren't doing that. We were taking a high-level national view. And he called me up asking why the counties in Eastern Kentucky were seeing their overdose mortality rates decline. And I'm like, really? I didn't know. So I looked at the data. I'm like, holy moly, he's right. So we got a meeting with the leading overdose researchers in the United States down at the Centers for Disease Control and Prevention, went down to Atlanta, shared the data, told them we wanted to do a study to understand what was happening in Eastern Kentucky, why were things going in the right direction and bucking this trend that we're seeing everywhere else in the country. And do you know what they told us? Oh no, you have to be looking at the data wrong. That can't be right. And they sent us away, politely, but they sent us away. 3 weeks later, I got a call. They said, okay, we had our own data analysts look at this. We would like you to do this study. And we partnered with the University of Kentucky Center for Excellence in Rural Health to do the study, but they actually funded us. They They were as oblivious to this as we were. So essentially, they gave us money to go all throughout Eastern Kentucky and talk to people about what was happening in Kentucky that was helping to change this dynamic. So CDC was the first people we needed to convince. You know who the second people were? The people in those communities. They didn't believe us either. Nor should they have, right? Because this is also true. So you see how these overdose mortality rates have declined? I mean, these are stunning declines. At the time that we did this study, the national overdose mortality rate was 25.5 per 100,000. The rates were still high. Need to celebrate the success of things going down, but the rates were still high. It didn't feel like they had achieved something. You know, I often tell people it doesn't matter whether you're 2 inches under the water or 20 feet under the water, you're still drowning. That's how it was feeling. So we had to convince the people in these communities. So just to put this in perspective, these 8 counties, I don't highlight them because they're the counties that were doing the best in Kentucky. I highlight them because these 8 counties are 8 of the 10 counties in the entire United States, 3,124 counties. 8 of the top 10 for decreased overdose mortality over that time period. That's stunning. Almost all persistent poverty counties. 14 of the top 20 were in Eastern Kentucky. That doesn't happen by accident. This is what we found. I'm not going to go into a lot of detail, but the expansion of Medicaid was huge, but not just the expansion of Medicaid. There was a really robust treatment benefit that was part of that expansion, but it even predated that expansion. There were groups, Operation Unite in particular, funding treatment vouchers, trying to get people into treatment before expansion. Once expansion happened and there was a way to pay for it, it blossomed. Recovery community initiatives, that's that recovery ecosystem I've been talking about. The criminal justice system got on board. Judges across Eastern Kentucky, many judges are more likely to refer people to treatment than incarceration. The state police have an initiative where you can walk into a state police barracks and they will take you to treatment. Probably not a lot of people do that, but you know who it impacted? Was the people who were working for the state police. It made them empathic, and that's what's important. Harm reduction is one that's amazing. That includes needle exchange. Would you guess that Kentucky is the leading state in the nation for harm reduction? The most harm reduction sites of any state in the United States here in Kentucky. Efforts to reduce stigma, primary prevention, all of these things together. It wasn't one thing, it was everything, and it was everything being done within a community and everything being done with political support, bipartisan. Okay, you had a Democratic governor, you had a Republican congressman, everybody came together to solve this. It was everybody's problem, and that made the difference. You know, I tell you about my Kentucky pride with my family. I look at this and like, this is amazing. Like, this doesn't cause pride, this causes envy. I want this for Tennessee. We do not have this in Tennessee. You know, the story I get in Tennessee is that we have people who wait 3, 4, 5 months to get into treatment. They're ready for treatment, and they're told come back in 4 or 5 months. Here in Kentucky, we talk to people who say if it takes more than an hour, it's a problem. That's the difference between life and death for a lot of people. So again, not to have rose-colored glasses, we do need to acknowledge that this study was done pre-COVID and everything went sideways during COVID, including in Kentucky. So your overdose mortality rates spiked just like everyone else's, but the systems and structures you have in place are still in place. You're going to be able to regain that lost ground in a lot more easy manner than we will in other states. These are those studies. They are on the NORC website, norc.org, if you want to read more about the study. And I'm happy to take any questions.
So one of the questions was about the slides being available. They are available on the Hoover app. So, and you can log into Hoover on your desktop PC or a tablet. And then another question we have online is, during the COVID response, issues getting the vaccine out and taken by the public was an issue. Some reported a lack of trust as the issue and not equity as the vaccine was out there and readily available. Do you feel there needs to be some concentration in gaining back trust by increasing education and informing the people of benefits and availability of care to meet their healthcare needs?
Yeah, I mean, it breaks my, as a public health professional, my whole career breaks my heart that our field took it on the chin during COVID. We lost a lot of trust with the public. And to me, one of the lessons learned from that is that we need to approach things ourselves with a little more humility. What happened was CDC would come out with a guidance and say it with absolute certainty. And then states and then locals would repeat it with absolute certainty. And they weren't certain and things would change. And every time something changed, a little bit of trust was lost. There's nothing wrong with saying we don't know. We're still learning. And in fact, that builds trust. And we need to take 2 steps back and approach things with a lot more humility and just acknowledge things we don't know. And I think that's going to go a long way moving forward. I will say, I do also think one of the challenges was the way that a lot of people, probably for bad reasons, took COVID and yet tried to use it for either political gain or to advance an agenda. The anti-vaccination groups came out of the woodwork. There were a lot of things that happened like that too. And any misstep we had was amplified because of that. So I think trying to figure out how we combat that misinformation is going to be another really important piece of it.
Okay, do we have any questions from the audience? All right.
I work for the Kentucky Hospital Association. I'm the director of quality. So we have 128 hospitals across the state. As far east as east goes, the entire Appalachian region hospital system. And then I work about 3 seconds away from Oldham County. Okay, so I get the difference. I can write a letter to my governor. I can get our hospitals to write letters to our governors, but this is an elephant. So if this is a call to action, which I absolutely believe it is, I don't know what the first bite is. Where do I begin?
Yeah, it's a tough question. So one of the things this isn't a direct answer to your question because I don't know if I have one. One of the things we're fortunate to have in the Appalachian region is the Appalachian Regional Commission, which is a federal agency that is dedicated to economic development within Appalachia. So that brings investment into the region. I think we need to replicate that in other places. It needs to go beyond Appalachia because Appalachia isn't the only struggling place in Kentucky or nationally. But I do think they have a model there. And I think at the end of the day, figuring out how do we create this reinvestment and how do we bring resources back to our rural communities. It is, to me, an economic development issue as much, if not more so, than a healthcare delivery issue.
Perfect, thank you. I think we have one more question online. My phone closed out. So what are we doing? What are we currently doing to promote public health in rural communities?
Yeah, so one of the things that is worth noting, and it's something I'm super excited about. So, what are we doing to promote public health in rural communities? Until recently, the entirety of the federal focus on rural was at HRSA, okay? HRSA, Health Resources and Services Administration, is a great agency, Federal Office of Rural Health Policy. We love them, great office, but they're working within the Health Care Access Agency. That's an important issue for rural areas. What was lacking was that same focus at CDC. And CDC in the last year was funded to establish an Office of Rural Health. And I think that by itself could be transformational. So we now have an Office of Rural Health within our National Public Health Agency as well. And I think that's going to help advance this and just bring our National Public Health Agency online with thinking about how do we engage with rural communities, how do we address these disparities. And the fact that they're redoing that report, looking at the leading causes of death, that is from that office. So I think that's a big step forward, and hopefully that takes a giant step in helping us help to advance that focus on rural public health.
Thank you. Thanks for speaking today. We appreciate everything.